Good afternoon. I'm Dr. Jesse Morse, a sports medicine physician here at the Osteopathic Center in Miami. So we're going to continue on with our lecture series, and this time we're going to talk about hip injuries, the different types of them, and realistically, which ones are serious, which ones are mild, and which ones you should stay ahead of so that it doesn't turn from mild to a moderate injury and then kind of going from there. So most people think, oh, if it's a hip injury, it must be in the joint. And that's not necessarily the case. So as you know, if you've watched any of my videos before, I'm a big proponent of models, kind of visualization. So most people think the hip is only in the joint. And when we think of it, it's essentially a ball and socket joint. So the leg moves and the ball holds the socket in place. Well, that's part of it, and that's a very important part, but there's a lot of structures outside of the hip that aren't in that balloon or capsule within the joint that can lead to you feeling pain in this area, but is not traditionally hip pain from an intra-articular perspective. So some of those are straightforward and common. I've had it several times just because of my exercise routine and the way I was positioning myself. Just because it's hip doesn't mean it's scary. Sometimes it's mild and it's not a big deal. You just need to do a couple things to tweak it. So I'm sure most people have probably heard of the phrase bursitis. Now, bursitis is a very vague term because nowadays they use it for everything. It used to be pretty specific, but we've lost that. The most common location for bursitis in the hip is on the outside of the hip, basically where the bone is. So if you were to reach on the side of your leg and you feel a little protrusion almost at the waistline, just below it, that is the quote-unquote bursa for the hip. It's what we call the greater trochanteric bursa. Now, the bursa is a small fluid-filled sac that is to protect inflammation or really rubbing between a tendon and a bone, and depending on where in the body it is. Now, think of it as a pillow without a pillowcase in it. So it's supposed to be flat, and you really don't even have to worry about it. It's not supposed to be, feeling it at all. But sometimes it gets inflamed, and in that little area that is basically a pillowcase with no pillow in it now swells up and is now a big pillow, and all you feel is significant tenderness. So if you push on the side of your area, on that side of the leg, and if you have a lot of tenderness that's point tender, that's usually the culprit. Now, the issue can be the bursa. It can be inflamed and it can be filled up with fluid. You put an ultrasound probe right on it and you can see it clear as day. But necessarily, that doesn't mean that that's the actual issue. That could be a symptom of the issue. Now, the most common cause of this type of injury, and this is the one that I've had and a lot of people have had, is actually the muscle group that attaches right there. So the glute medius muscle group attaches right there and also attaches to the back part of the hip. So realistically, you can have a glute medius pain in the back part of the hip. That's what athletes will call a hip pointer, which is basically a bruise of this area. Or you can have it at the leg, which is much more common and much more painful. That's where most of us are going to have it, and it just kind of throbs. Now, the way this is situated is it goes muscle, tendon, bone. The tendon doesn't heal well, and it kind of tears like a rope. So if it starts to fray, and every time you pick up your leg, the muscle is pulling on the tendon, which is pulling on the bone and lifting that leg, you're going to start to get some inflammation in that tendon if you're doing it over and over again, and the body can't heal it. So a lot of the times, you need to calm down this area. Therapy can work well. Sometimes they have to do dry needling or a little bit more aggressive means. Maybe they use manual manipulation like a Graston technique. But if it doesn't calm down and doesn't go away, and it can be very debilitating, you sometimes need to help it out with a little bit of an injection. You can use steroids, but it doesn't structurally change anything. It just helps the healing a little bit and more so swelling. So realistically, you're going to want to put something in there that can heal the tissue, that can ideally fix it and prevent it to coming back. And oftentimes, for a milder case, or sometimes even the moderate ones, you can get away with PRP. In general, that's a very common injury, not super concerning. Okay, so what's another common injury to the hip that is not inside of the joint? Now, realistically, this usually happens more in very athletic people that exercise a lot. A lot of our professional athletes have this. This is something called a hip flexor. Now, at the front of the hip, where the quadriceps or the muscles on the top of your leg, where those come up and insert, basically, they essentially insert right here. If you can see this little protrusions, they come up and attach here. So you can have significant pain kind of almost at the groin, but it's a little bit kind of closer to the side of the hip. And the problem is when that throbs, it can be very uncomfortable, especially if you go from kind of sedentary and then you start ramping it up and you really start having a lot of activity. That tendon, same issue, different location, again starts to throb. It's like, I can't keep up with how much you're asking me. And all of the force of that quad is pulling on that flexor tendon. And a lot of times it just can't handle the amount of constant torture that you're asking it to do, so it lets you know. This is more of the same in terms of how to treat it. You can do therapy. Oftentimes that will be enough. But if you need to, sometimes I've seen partial tears of these where think of it as a piece of rope and then half of the rope is really not much attached anymore. So now you're asking the whole quad to fire on half of a tendon, which usually doesn't do well, and over time either causes a lot of pain or fully tears. So you don't want it to fully tear, obviously, because then if it's supposed to be here, now it's down here hanging and you need surgery and there's no choice about it. If you can get ahead of it, then you can actually consider putting something in the area that can help improve the tissue, improve the blood flow, and ideally regrow new tissue, which is what regenerative medicine is. And at that point, you can maybe not even worry about it anymore because you've started the cascade of healing. Now, as part of the hip flexor, before I forget, there is another muscle group that is called the psoas, which is a very interesting muscle. It actually starts in the front and essentially goes to the back. So it starts essentially in the front and it runs through the pelvis and actually attaches to the spine, the sides of the spine. So, and they're pretty strong. So if one is firing, it will literally have you like twisted. It's fascinating. It's very, very powerful muscle group that when it's angry, it can throw off your whole alignment. So that's another thing that sometimes needs to be addressed and corrected and make sure it's loose so that it's not throwing off everything else. Because these things are supposed to be even. They're supposed to be the same length. But if everything's thrown out of alignment, then that ligament and tendon and muscle group that's supposed to be the same length, but now is sitting on something that's a little higher, is going to be under more tension. Therefore, it's under more stress and more likely to suffer an injury if it's being pushed. So those are two types of hip injuries that most people don't really think of. You have a hip pointer, like I mentioned in the back recently. It's in the back part of the hip. This usually is when you land on your hip. Think of slipping and falling and kind of landing on your back. But you really land on kind of the top part of your hip as opposed to your actual back. That is an uncomfortable pain, but it doesn't really structurally concern me per se. You'll be in pain for a week or two. You might have a little bit of bruising of that bone, but usually there's not a whole lot of damage. So now we're going to enter the realm of normal, what people think of as a hip injury. So within the hip joint, think of the hip joint as a balloon. Okay, just like the knee, the hip is a big balloon. That's called the capsule. So the capsule in housing contains all of the important structures within the hip. Now, in order to get any medicines inside of the hip, you actually have to stick a needle through the capsule, through the balloon, inside. It doesn't penetrate well without that. So you actually have to go inside of that balloon. Usually we don't do it blind if we can help it, because there's a lot of important nerves and muscles and, more importantly, blood vessels in the area that you do not want to get into. So you realistically either use ultrasound guidance, which is what I use, or some people also use x-ray guidance as well. So there's two main injuries that we're talking about in here. I have a good model for arthritis, which we'll talk about in a sec. A little bit of labral tearing is a little bit harder to discuss, but I can paint a good mental picture for you. The dichotomy is very important here. Young people usually have labral tears, and that's their main culprit. The main issue is that as we get older, then the arthritis starts to develop. All right, so we've had some interruptions. You haven't seen them because I paused the video, but if it looks a little choppy, that's why. So as far as arthritis is very frustrating, especially in the hip. Because it's a weight-bearing joint, us being bipedal and upright, we are going to get wear and tear on predominantly three areas of our body: our low back, our hips, and our knees. Thankfully, our ankles get spared. We can get arthritis in our hands, unfortunately, but usually we don't do a whole lot in the elbows, and we don't get a whole lot in the shoulder. We can, it's just not very common. One of my theories is we're not walking on our hands. So with that being said, unfortunately, the hips do and can get arthritic. Now, within each hip, there is an important structure called a labrum. We have a labrum in each hip, and we have a labrum in each shoulder. Now, the labrum is a thick piece of cartilage that holds the ball onto the socket. So without the labrum, this would just completely fall off. And the problem with the labrum, look at it as, it's not really this, but on the model, it basically insinuates this. So this holds this leg bone into the socket. Without that, it's like a golf ball struggling to sit on a golf tee. It won't stay on there when you're trying to do what you need to do. Now, if you happen to be blessed or cursed, depending on how you look at it, with a genetic predisposition called FAI, or femoral acetabular impingement, you have a higher risk of suffering a labral tear earlier in life. Now, what does that entail? And I'm going to do this briefly because a lot of people don't even know they have it unless they have x-rays or they have an MRI to prove that it's there. You won't know it otherwise. But I've seen, people as early as 14 with a labral tear in their hip because they had FAI and because they were so active. If they weren't as active, unfortunately, they probably wouldn't have had the tear, but we're trying to promote activity, not disable it. So what usually happens in FAI? There's two possibilities. The neck of the proximal leg bone is wider than it should be. It should taper down, and as a result, it leads to tearing of that labrum. That's one option. The other one is you can have a excessive bone that basically rubs, and every time you pick up your leg bone, it tears that labrum right there. The most common is actually what we call a mixed type, which means you basically get both. And every single time you pick up your leg bone, and this is one of my favorite models. You pick up your leg bone, and you can see here the ball and the labrum. This is the blue part's the labrum, or really the cartilage. It starts to tear it. Now, if there's excessive bone growth at this part right here, you're going to tear that labrum. Now, think of this labrum as a big clock. So 12, 1, 2, all the way around. So noon would be at the top, 6 would be at the bottom, 3 would be towards the front of the hip, and 9 would be basically at the back part of the hip. So if you have a tear between 12 and 1, not super concerning, not that big. But if you have a tear between 12 and 6, that's half of your labrum. Every time you try to move a certain direction, and say it's right here, and the force is trying to push that leg, well, the labrum can't hold the ball into the socket. So it's literally like, doop, just going to pop right out, just like a shoulder dislocation. That can happen, and the more instability of the labral tearing, the more this causes pain. The other thing that it does is it starts to wear down on the articular cartilage, the protective layer around the bone. So as you can see here, you can see that, you see how there's a little bit of red right there? That's wearing down. You can see the socket, it's starting to wear down. This would be mild arthritis. Now, what happens when it starts to really get worse? Look at how crazy that is. Think about it. Look, that's exposed bone. That's pain every single time you move your leg. Look at how much damage is inside of the cartilage, inside of the labrum. This is severe end-stage arthritis that usually requires a hip replacement. You don't want it to get there. You can prevent some of this if you tighten up the joint and instability and coat this inside of this joint with different products that can help provide nutrition to that cartilage. Now, the worse the labral tear, the worse the cartilage injury is going to be, and the more pain you're going to be in. Now, if some of the things that most people don't take into consideration, which is one of the things we do here, is we look at the joint as a whole. You don't just put an injection into the balloon, into the capsule, and hope everything is fixed. You're not tightening up all the structures that are responsible for that hip. Think of it as a car engine, and the bolts are loose. Every time you push it, the bolts are going to go crazy and the engine's going to move like crazy. In this analogy, the bolts are the ligaments, and the engine would be the hip. So if you can tighten up the ligaments, when you push it, the hip just like, oh, we're good. But if you don't tighten up the ligaments, then every time you push it, there's way too much movement, and it becomes unstable. When you have instability, the body says, no, I don't like that. I'm going to tighten up all the muscles in the area to protect that hip. You can get a massage to decrease the stress on the muscles, but if you didn't fix the source, when you start pushing it again, the muscle's like, ooh, there's still an injury, and they tighten up again. So there's this vicious cycle. So you have to correct the source. When you correct the source, the muscles go back to doing their job, which is movement, not protection. And in that regard, you start seeing progress. Describe what a hip tear, a labral tear, feels like. Sharp stabbing pain with certain ranges of motion. Classic. That's exactly what everyone describes. They may have it at an angle up and out like this. They may have it with kind of a weird motion when you're bringing your knee kind of in like that. It really depends on where that labrum is torn. The larger the tear, the more you're going to feel it with certain ranges of motion. If it's bad enough, a lot of the times people will have this repaired. And it's a good surgery, but it takes like 3 to 6 months to start to feel normal again. That's a long time. We approach it a little bit differently. Unless it's a bad tear, then we usually approach it with injections, and we're basically stabilizing not only the labrum and tightening up the labrum, but we're also coating the cartilage on the inside and providing nutrition to that. But we also tighten up the ligaments, literally through injections, usually 3, one in the front, one in kind of the top/side, and one in the back, kind of the posterior approach. Now, when you do that, the hip's like, oh, I'm strong again. I can actually handle what you're asking, and I don't have to feel all wobbly like a loose leg on a chair. If you tighten up that leg, it can handle what you're asking it to do. The rate limiting factor is how much articular cartilage is damaged inside of that joint. So even if you have bad end-stage arthritis in your hip like this, If you stabilize the entire joint, that might be able to buy you 5 years, 10 years. Because you really can't reverse this back to normal when you were 20 or whatever. But you can tighten up this entire joint and buy your hip enough time. Now, surgery is very effective for all these things. But at the end of the day, it's still surgery, and there are still risks and there's still side effects. Some people, 20, maybe 25%, have an issue with their surgery. Once you get a replacement, a hip replacement, you lose the ability to inject that hip thereafter. It's too risky. You can't do it. So you have to understand that. Can you run? Can you be active on a hip replacement? Yes. Are you probably going to decrease the half-life and probably have to have a hip replacement sooner, a second one, than if you weren't as active? Yes. They will never make a hip replacement that is as good as our hip. And they're really good. A lot of it also depends on the approach of the replacement. If you're doing a traditional approach versus a non-traditional approach, there are ways to get you back quicker, but not every surgeon does it the same way. And different protocols, different schools of thought, different training lead to different outcomes. So that's why some people do great, and then some people didn't. Maybe the ball and socket was the wrong size. Maybe there was an infection. Maybe there was another injury that wasn't properly addressed. So once you go in, that's it. There's no turning back. And finding someone to fix a revision of a hip or a knee is a nightmare, because they don't want to deal with someone else's problem. And unfortunately, insurance doesn't pay really much, or if not more than anything normal, to fix it. But it takes 2 or 3 times as long. So the goal in my mind would be prevent from getting there in the first place. So best case scenario, you are more proactive than reactive. And I can't stress this enough. If it's mild, don't assume it's going to go away. You give it a couple weeks, you're like, this isn't going away, and I feel like it's only getting worse. Address it now. It's a lot easier to address something that's mild than it is moderate or severe. Once that damage is done, once all those compensatory mechanisms, your body's developed, I'm going to do this in order to prevent pain from that, the body will keep on rolling. The problem is you're creating issues that you might not be able to ever properly fix. If you addressed it early, not a big deal. You can correct it and you may not ever have any new compensation patterns. Think of an alignment in a car. If it's a little bit out of whack and you go ahead and you get it aligned and everything in the tire, everything's back to normal, you're good. But what if you wait 6 months to a year? Now, the bearings on one side may be off. The wear pattern is going to be off. Everything's off because it's been riding crazy the whole year. That's how we are. Your body is going to continue to keep pushing. The problem is you're going to develop things that you might not be able to revert and reverse. And my goal is to at least help you understand that you can address these things early. Not every place might do it, and unfortunately it might not be covered by insurance, and that's a separate discussion for a separate day. But that doesn't mean it doesn't exist, and that doesn't mean it can't help. The last couple things I want to talk about. What does classic hip arthritis feel like? Throbbing, aching pain. As it gets worse, it feels like your leg, it weighs 1,000,000 pounds. You literally are like dragging it, okay? The other thing that patients used to tell me all the time when I predominantly practiced traditional orthopedics was, I feel like I can't get a comfortable position at night, especially if I sleep on my side. So if you're laying on your back, it's usually not as bad. And a lot of people will put a pillow underneath their legs to kind of give them a little bit of an alignment change. But if you're a side sleeper and you have bad arthritis, usually you can't sleep with the bad side up, because what happens is you are basically putting this heavy leg is angling, and you're going to cause a significant rubbing between the ball and the socket, and you're going to have this throbbing all night. So that's why a lot of people will say, I put a pillow in between my legs to kind of make them even. that tells you that you either have a bad labral tear or you have moderate arthritis at the minimum. And you can prevent that from getting worse. This becomes very debilitating. You start saying, nah, I don't want to do that. No, I don't want to do that. And you get to a point where like it literally took over your life and you just want your life back. I get it. But if you prevent this from happening or prevent, slow it down in an ideal situation, then, maybe you buy 10, 15, 20 years of normalcy with your hip before you have to, unfortunately, undergo a hip replacement, which for some people is inevitable. Okay, the last thing that I want to talk about here. So, it'll be a two-part comment. 75% of hip pain is in the groin. Okay? True hip pain usually is in the groin. But there's about 20 to 25% of patients, at least based on my experience, that they present with back pain. But it's actually hip. It's actually hip. So because of the way we're structured, you may feel it in the front, and most people feel it in the front. But a lot of people feel it in the back, and they just describe it as back pain. But it's not the back. It's the hip. So oftentimes, when we have patients here that have a bad, presenting with back pain or a hip pain, we will do both the back and the hip. Because if you just correct the hip and don't evaluate the back, you may be only hitting half of the injury. You have to see which one is which. And another thing, we often do is something called a Lidocaine Block. So what we'll do is we'll actually inject lidocaine, a local numbing medicine that turns off the pain pretty much immediately to the brain, and we will inject it in very specific locations. Say if we're trying to say, is this all hip? Is 100% of your pain coming from your hip? Is 50% of it? So you block just the hip. You do 3 or 4 injections. You're numbing up, you put some in the joint, you put it in a couple places. Within 5 minutes, you're not touching the back at all. What percentage of your pain is gone? 100% of my pain is gone. It's all your hip. No question. 50% of my pain is gone. All right. Only 50% of your pain is coming from your hip. Now we get to figure out where the other 50% is coming from. If your doctor isn't willing to do this, you know where to find me. Not everybody will do it, and sometimes it takes extra time. But as my dad, who is a carpenter, told me, measure twice and cut once. Once that medicine's in there, it's not coming out. Make sure you know what you're treating. No shotgun approaches. Finally, if this is a back issue, the tricky part is which one is controlling the show, or is it half and half? If you're only thinking it's your hip because you think it's in your hip, but some of this culprit is actually your back, and you only address the hip, you're still going to be in pain and you're going to be disappointed. That doctor's not going to look very good, he or she, because A, he didn't fix the whole issue, or he or she didn't fix the whole issue, or B, they only checked one part. You have to look at both parts when you are evaluating a hip. The back loves to come and play, and sometimes it's not obvious. That's what makes this area very tricky. There is a gray area here. And one of my favorite phrases, that's why we call it practicing medicine. There's a lot of gray area. If you like this lecture, do me a favor, smash the like button and the subscribe. Check out some of the other lectures. Let me know in the comments which other topics you may consider. I've tried to do some. These usually take anywhere from 20 to 30 minutes to do, and I probably do them every couple weeks or so. If you have any questions, we are happy to do a consult. We are in Miami. We also have an office in Knoxville, and we do Zoom calls. We can do telephone conferences. If you can't come down here, I get it. But if you just want a second opinion or third opinion or someone that looks at it a little bit differently, we are happy to help. Thank you for tuning in. We'll see you next time.